Okay, good evening everyone. I am Dr. Murali Chand from India. Today, I will describe about mid-pupillary line. This mid-pupillary line, vertically like this. In face surgery, whatever the pathology lateral to the mid-pupillary line in the frontal sinus, all these years, the recommendation is we have to do open approach. Suppose the pathology is lateral to the mid-pupillary line in the frontal sinus, that we have to remove by open approach, not by FES. But now, recently, Professor Paolo Castello from Italy, he recommended orbital transposition. What exactly we are doing in orbital transposition is, we are removing the lamina papyracea in the orbit and at the frontal recess area also. Suppose if there is supraorbital cell at that area also, and then we are transposing the orbit laterally, and then to the face we are trying to reach the lateral end of the frontal sinus, lateral to this mid-pupillary line. That means he is removing the lamina papyracea medially and superiorly also. That means medially lamina papyracea, and here if the supraorbital cell present, it is the supraorbital cell, lamina papyracea, and then superiorly. So the whole bony covering of the medial part of the orbit is removed to the face and to the nose and the frontal recess and the supraorbital cell area and the upper part of the floor of the frontal sinus also. Then transpose orbit laterally and then remove the pathology lateral to this mid-pupillary line. But in this, you need lot of expertise, you need instrumentation, curved instruments, curved drills, curved debriders with 70-degree scope. You need lot of expertise. But in fact, my question is, do we really need orbital transposition? That is my question. The answer is no. All these years, if the pathology is lateral to the mid-pupillary line, we are removing that pathology by open approaches, whether it may be brow incision or bicoronal incision, and then approaching the frontal sinus area lateral to the mid-pupillary line. I will tell you one example where we face real crisis. We are approaching there is lymphoma here. Lymphoma is something we don't know preoperatively. We are taking the biopsy, excision biopsy, and we are trying to approach the tumor which is present lateral to the mid-pupillary line through the nose. Somehow it bleeded like anything, and then we packed the nose and we deferred the procedure. And unfortunately, within 4 hours, that patient went into unconsciousness. And the CT scan shows there is hematoma in the frontal lobe area. So instead of trickling of bleeding to the nose, the blood has gone into the frontal lobe from the posterior table, dehiscent posterior table of the frontal sinus. So immediately we did brow incision and retractor, kept a mastoid retractor and incised the periosteum, and then we made a small window and we just scooped it out. Just half an hour procedure. So always, even in this endoscopic era also, never forget good traditional old open approaches. These open approaches are still valid, and they are cost effective also. Just imagine for doing this fast surgery to the nose, how much equipment we needed. All these things are not necessary. With the latest developments of FACE and anti-skull base, these open approaches are forgotten. Actually, they are needed, even in this FACE era also, even in the anti-skull base era also. So whatever the pathology medial to the mid-pupil line, you can remove by the FACE, and lateral to the mid-pupil line, you can give brow incision. Very simple, just 5 to 10 minutes job. After incising the periosteum, you just make a small hole with our regular mastoid burr just above this orbital rim, and dilate that hole with our nebulous. Keep an endoscope. Slowly you dilate it, and then remove the pathology. Or if you want to make a bigger hole, take a dental burr and make dental cutting burr, and make a 1 into 1 centimeter or 1.5 into 1.5 centimeter big hole, and then you can apply suture, or you can plate it also. So very simple. So that is very important. The point what I want to convey is, still even this endoscopic era or anti-skull base era also, open skull base approaches are still valid. Okay. And next is the mid-pupillary line. Another importance is, if you come below and this is the vertical line, and the transverse line at our columella or lower alar region, transverse line, the intersecting point is the entry point of our cardiac. So in that way you can approach the maxillary sinus by giving midfacial degloving here, incision, and you make a hole here, and you can enter into the frontal sinus. That is the importance of our mid-pupillary line. So my final message is, even in this endoscopic era also, even in this anti-skull base era also, open approaches are still valid. Okay, thank you.